next, I would like to go ahead and introduce our two speakers. We have Dr. Heather Bleacher. She's an associate professor in the Department of Family Medicine at the University of Colorado. She serves as a director of community health initiatives and outcomes and has co-led family medicine residency community health curriculum focused on population health, advocacy, and community engagement since 2012. Her work centers on helping clinics and training programs build more inclusive, community responsive care. And we also have Dr. Brianna Muller, and she is a family medicine physician in Shiprock, New Mexico, and is faculty for the UNM Shiprock Family Medicine Residency. She leads a community health curriculum and has worked in Shiprock since graduating from residency in 2021. We would like to go ahead and get started. Dr. Bleacher.
Okay, great. All right. Hold on, I just need to rearrange my windows quickly because all my video people moved. So just give me a quick second. Okay. All right. Good afternoon. We'll get things started. So what our learning objectives are today for this session are to, one, describe various, aka 2 different models for community engagement in residency education, explore the successes and challenges that are just a part of community engagement in residency settings, and discuss some possible next steps for strengthening community engagement experiences. So I know that we covered this last time, but I really do want to just start us all with a reminder about these 2 resources. There are practices and ways of working with community that contribute to trusting, mutually beneficial, and enduring partnerships. These 2 guides really provide eloquent and insightful summaries of these practices, and I recommend reading and revisiting them often. These are just sort of one-word summaries of each of them that don't capture everything that is written in the guides, but none of these principles are surprising. But like any set of values, I think that taking the time to deliberately revisit and reflect on how we are doing these things and how we strive to be is really important. So just another plug that if you have not taken a look at those guides, please do it. Because it'll just be a nice grounding exercise. So I'm going to just move right into talking about the curriculum that I direct at the University of Colorado Family Medicine Residency. So our residency, excuse me, we are located in Denver, Colorado. We have 11 residents each year. We have 2 tracks. One track is our Denver Health track that we have 5 residents. They practice at an FQHC, the Lowry Family Health Center. And our other track, University track, they practice their continuity clinic at a more traditional sort of a hospital primary care network practice. Other than those 2 continuity clinic sites, actually the resident curriculum and residency experiences are really similar between the 2 tracks, and they get a pretty uniform experience otherwise. And so my curriculum, my community health curriculum, is one of several longitudinal threads that pass through all 3 years of residency. So I call my curriculum the FACE curriculum, and that stands for Public and Population Health, Advocacy, and Community Engagement. Those are sort of the core buckets that we really focus on. And, when I explain this, I kind of say we need those public and population health skills and our community engagement practices to really learn about and understand health inequities that are in the neighborhoods and communities that we're serving. And then we need those same skills plus advocacy as levers for actually doing something about what we find. And I love a adequate to great acronym, so I made one. So our key learning objectives for the curriculum are 1, to identify health inequities and their root causes. 2, to describe the relationship between primary care and public health and really think about what are the opportunities for collaboration. third is around community engagement and examining how community engagement and primary care are related, and really to do some exploration and examination around what is a physician's responsibility as a partner to their community, not just their patients. 4 is to become an advocate for the health of their patients and community, and then to develop skills to act effectively in that capacity. And then finally is to be able to employ effective strategies to improve the health of the population, all leading towards health equity. So I'm just going to walk you through how our curriculum unfolds over all 3 years. Our intern year, our residents have these really cool rotational blocks called chautauquas, and those happen kind of where those green blocks are in that graphic in the top right. So roughly July, November, and May to June each year, the intern class all comes together, and they have a variety of different lectures. They have more continuity clinic. They'll have didactic content that's really geared up to try to help prepare them for their next block of rotations. So they'll have OB focused content or MICU focused content, et cetera. And then that's where I also get a substantial portion of time for my curriculum. So in Chautauqua 1, we're really just kind of setting the stage. So I do an overview presentation about what is the FACE curriculum, what do we teach it, why, how do we do it? And then we visit the History Colorado Center, which is a really excellent museum in Denver that I think is really useful for grounding new interns. A lot of them are not from Colorado, have never lived in Colorado. It's a way to learn a little bit about what has happened in this state before they walked in. So we kick things off that way. We work with a community health liaison to organize a neighborhood walking tour in the Aurora community, where a lot of our patients come from, whether they're continuity clinic patients or patients that they'll be taking care of in the hospital. And they take us around to visit various organizations and community leaders to give their perspective of the assets in the neighborhood. We do that with a service activity with a community partner. In the past, we've done volunteering at a community garden or working in a food pantry to help get things set up for that organization. We do a whole half day on healthcare for people experiencing homelessness. We go to our Stout Street Clinic, which is in downtown Denver, which is geared towards providing care for people experiencing homelessness. They have a street outreach team. So those presenters will talk about what kind of services they offer, but also give some clinical teaching around, what are the root causes of homelessness? Like, what are some of the medical considerations? Why approaches to substance use in these populations, et cetera. And then we do an activity, should be no surprise to anybody who's seen this, on the principles of community engagement and trustworthiness. And there's some of our beaming, they're not interns anymore, they're out there practicing in the world, but they are at their service day. In Chautauqua 2, so now we're into October or November, we start focusing on the public health side of things. So we will have presentations from folks from our local and state public health entities talking about how they function, what do they do. They'll share the community health assessments that they have done on the public health side. And then we do a self-contained project called the Mini Community Health Assessment Project, where the residents are grouped into neighborhoods that their patients come from, that they otherwise probably wouldn't go visit on their own. And they do a combination of a walking tour of the neighborhood. They access public health data. They meet with leaders from a community organization to sort of try to formulate, okay, what are the health assets and health challenges in this neighborhood? And then they do a presentation to their peers, to which we invite the partner community organizations to come and attend the presentation so that they can participate in that conversation. And then Chautauqua 3, at the end of intern year, we're in the middle of it right now. I'm in between these two sessions actually this week. Tomorrow we head off to our advocacy and policy day. We go down to the Colorado State Capitol, We hear from physicians who have active roles in influencing policy, whether it's through advocacy or public office ways. We we try to arrange a legislator panel with our state legislators, and we always, every year, we start off with 3 folks who are like, yes, we'll be there. And then by the day of, it's a person, but it's still very valuable. You know, it gives the residents a chance to interface with someone who's right there making legislation and hearing their perspectives on how physicians can be involved in advocacy and can become like a trusted advisor to legislators if that's something they're interested in. They do a couple of different advocacy workshops. One is just an introduction to advocacy. And then another one is an op-ed writing for advocacy workshop where they take an actual issue, and they learn sort of basic principles about how to do the writing, and they draft an op-ed themselves. And then yesterday, we were just doing our community responsive primary care morning. We spend the morning at an FQHC in the neighborhood that none of them practice at, called Tepeyac Community Health Center. And we learn about all the really innovative ways that they have adapted their care model and the services that they provide to care for the particular community that is their patient panel. We hear about medical legal partnerships and talk about the idea of like social barriers to health with legal remedies and how can they go about trying to address those. And then a presentation on Latino health in Colorado and community health workers, since that's a significant population in Colorado that a lot of our residents are going to care for, and just want to get them that foundational information there. This is an example of our one-person panel from several years ago from COVID times. This is our residents meeting with then Representative Yadira Caraveo down at the Capitol. She talked to them about her experiences unionizing her residency. They were very moved by that one. All right, year 2, we only get 4 half days with the residents, and they're all in the same block towards the end of the year. We do 4 main things. We have a community health program planning workshop, which I will talk about in a moment. We go back down to the Colorado State Capitol to hear legislative hearings. Now the legislature is actually in session. It was not for that Chautauqua 3 session, but now it's in session, and they can go and they can actually see how people testify in real time and learn more about the process, about how bills are passed and whatnot. They have a testimony workshop where they take an issue that is actually going through our state legislature and they develop a 2-minute testimony. And we've had many residents, we usually have 1 or 2 each year, that actually take that testimony and deliver it to a hearing at the Capitol. So that one's a really nice tangible skill developer. And then again, we plug in another service activity. We are trying to focus that on doing those service activities with the organizations that they met with in Chautauqua 2 for their mini community health assessment. So trying to add some reciprocity there. So the community health program planning workshop, basically a colleague of mine and I, we went through, we got our public health degrees together at the same time. And when we finished, we were both like, you know, what our residents really need is something that's more than just the, I have a great idea, so I'm going to do it model of planning a project. And so we do a really, really distilled version of what we learned getting our master's, and just try to encourage them and give them some framing and questions to take with them around, okay, first you want to really understand, like, who are you serving? What is the actual health problem? Then you can decide what you think you need to do, and then how are you going to evaluate it, and how are you going to engage the community all along the way. And then year 3 is really kind of a potpourri. So we have time with our residents on the second and fourth Thursdays of certain blocks where it makes sense. So on their mostly outpatient rotations. And so it'll be every block, it'll be a different grab bag of residents that we have for any given session. So one thing that we have done, so our 3rd-year residents, they all have to do a quality improvement project. So we've tried to add sort of a face lens to some of those QI projects to help them think more broadly about what are some of the social or community factors that could be at play or influencing things. So for like a couple of years ago, we went and toured a local mosque and met with the imam and asked questions about cultural considerations in advanced care planning in that religious context, because the residents were working on advanced care planning in their clinic, so that kind of thing. We have relationships with several local healthcare pathway programs, so programs with students, like high school students who are underrepresented in medicine, and we will sort of plug into that overarching curriculum that exists, and we'll deliver a few seminars to the students there and talk about family medicine, talk about health inequities, et cetera. Each of the residents has to complete an independent advocacy activity where they attend a stakeholder meeting and then do one thing to practice advocacy. It could be delivering oral testimony. It could be writing an op-ed. It could be, if they're like really involved in the GME committee, if they're advocating for something in that context, that counts too. We just want them to continue practicing the skills that they've been learning all along. We'll attend various government or other stakeholder meetings. So we've gone to school board meetings in the past. We'll try to go to city council meetings, et cetera. And then, we'll do various meetings or tours with community organizations that provide enabling services for the patients that they take care of. This is a photo of some of our third-year residents presenting at the Pathways program. It does look like possibly 2 of the residents are asleep in this moment. I assure you they were not, but yeah. So I've just been talking at you a whole lot just to sort of sum up some of my takeaways from leading the curriculum for so long. So some of the successes at a really fundamental level, we have just a strong structure. Like we have really quite a bit of time. Things are thought out intentionally, and they get to learn a lot about a lot of different things. I think that we do a nice job of emphasizing equity and trying to make sure that everything is pointed back to that as the ultimate goal and not just engagement for engagement's sake. They have a really wide breadth of exposure, right? We're taking them all over the place. And then they have a lot of opportunities for really tangible advocacy skill building. All of those workshops, are really meant for them to have something, a product at the end of them. And the residents always have really great reviews about the advocacy workshops in their evaluations. Things that we wrestle with. One would be a lack of longitudinal community engagement experiences. We have a lot of faculty who kind of individually have more ongoing partnerships with community organizations or community spaces, but as a residency, we have the things that I have built and they're not the most robust. I think tied in with that is evolving resident expectations. I think that we're seeing a lot of residents who wanted to dive right in and get into engagement right up to their elbows right off the bat, and just seem to have less enthusiasm for sort of like building the foundation that's real of like understanding that's needed before you dive right into the engagement. We have 2 tracks that serve really different communities. Our Denver Health Track, their Lowry Clinic serves over 50% of that patient population are patients who speak languages other than English or Spanish. And they have a really robust refugee and immigrant population. And then on our university side, their patient population at their continuity clinic is just not as diverse. And so trying to make sure that we have opportunities that resonate on all sides can be a little bit tricky. And then, this is going to be the case for anybody is just resident schedules are the worst. It doesn't matter what you're trying to do. They are terrible and get in the way of everything. And then pair that with really varying interest levels. Like, I said, people want to jump right into their elbows, and then we have other people who walk in and it's just not their thing, and that's okay. So trying to figure out like what's the bare minimum that everybody needs, and then try to figure out what are the opportunities for the people who really want to dive in is just a challenge. So last thing you're going to hear from me. So what are the things that I'm currently working on to improve the curriculum? One is that this year we're going to be expanding the mini community health assessment project. We have traditionally had it start and stop just in Chautauqua 2, which is it's not much time. And we've always been really clear, like it's not much time. We know it's not enough time. Do your best. But now we're going to introduce it at the beginning of the year. We're going to have them present at the end of the year and try to figure out how we can support them to keep momentum throughout the year, and see if that helps. And then our third year, which is right now, like I said, everything is just kind of potpourri. We're going to work on trying to figure out how we can partner our residents with those faculty members who have those relationships, so that they can continue to work with that faculty member in that community setting throughout the year. And we'll still have some potpourri, but trying to work on, the more meaningful ongoing engagement. So that is it from me. I'm going to hand it over to Brianna, and I'm going to stop sharing, and we'll do questions at the end.
All right, I'm realizing if you stop sharing, I don't know, I guess in order to control the slides, I have to have them pulled up. So if you actually don't mind.
No, I don't mind.
Advancing them for me, I apologize. I didn't think through that. I thought they could just give control of the present or make me the host or something like that.
They should have that feature, but they haven't created it yet. So just let me know what you want me to
Perfect. I'll give you like a thumbs up or something. Thank you so much. Thanks, Heather. It's super interesting to hear what different places are doing, because I think, as you'll kind of see, we have, I think, a much less formalized structure and curriculum that's been sort of iterative, and just learning what different places are doing provides a lot of idea generation for me. So that's really cool to hear about. So my name is Brianna Muller. I am on faculty at the UNM Shiprock Family Medicine Residency in Shiprock, New Mexico. We're in the Four Corners area. Go ahead and advance slide, please. We are a 1+2 program, which I'll talk a little bit about in a second, that was established not too long ago in 2021 out of a HRSA grant trying to increase rural residency programs. And we are the first federal Indian Health Service residency program in the country. So you can go to the next slide. Essentially, we have 2 residents a year, and they spend their first year at the University of New Mexico in Albuquerque at a large tertiary care center, spending time in a high volume, high acuity environment in Albuquerque. And then for their second 2 years, they come to Shiprock, Northern Navajo Medical Center, which we have an outpatient clinic, and we have a 50-bed inpatient hospital that's on the Navajo Nation. They're about 200 miles from one another, 3.5 to 4 hours, depending on how quick you drive. So it is very rural, and gives the residents a pretty different experience from year 1 to 2 to 3. Go to the next slide. Thank you. And just for context for folks who aren't aware, the Navajo Nation, or Diné Bika, I forgive the pronunciation. Diné is a very hard language, and so I know I did not say it correctly, but the Navajo Nation is very large. It's the size of West Virginia, about 27,000 square miles. Shiprock is in the northeast corner, and our hospital serves the 80,000 people that live in that area. Navajo Nation has about 165,000 people total that live here, but there are about 400,000 tribal members kind of spread throughout the country. It is a sovereign nation, and that kind of will come into context later. It has made some sort of elements of community engagement a little bit more nuanced, which I'll talk about. You can click, Heather, there's a picture that's going to come in. So each agency is broken up into chapters, and chapters are sort of the community hubs. There's a chapter house where the local government gathers and serves as a resource for community. There's oftentimes a senior center, and Shiprock Service Unit has about 20 chapters, depending on how you ask. It's counted differently in different entities. And this map shows just kind of the area that we're covering. So driving wise, to the edge of our catchment area, it can take for folks who live off of on unpaved roads, we have people who drive 2.5 to 3 hours to see us at the hospital. You can go to the next slide. So our learning objectives for our rotation, really, I think the sort of fundamental approach that we are entering into our curriculum with is that for many residents who are coming to our program, they do not have an extensive experience working in Indigenous communities or on the Navajo Nation, and really having a lot of humility around, as one of the residents put it the other day, they're just a baby in terms of what they sort of know, and that we are guests and have a lot to learn, and really want to have as much community sort of wisdom imbued in our curriculum as possible. Objective-wise, one of the hopes is that residents will understand the health profile of the Navajo Nation and the historical, structural, and social determinants that drive health inequities in our community. We want them to be able to deliver culturally humble and patient-centered care within our system, integrating Dene cultural values and community resources. Dene is the self-given name for the Navajo. We want them to be able to collaborate with our community health infrastructure that already exists here. We have a really robust community health, public health infrastructure, including community health representatives, public health nurses, and community partners to address health needs at the individual and population level. And we hope that people can advocate for health equity by identifying structural barriers to care and acting as effective community partners for our patients here on the Navajo Nation. And I should mention, it's a little bit of a unique situation. So we're kind of on the border of the reservation. And so we also serve a town called Farmington. That's about 50,000 people, or Indigenous people who live in Farmington. And it's more of a suburban community. So it's interesting. We have kind of a wide community, means a lot of different things in different places, depending on where our residents are in, any given day. So, but like I mentioned, one of the big things that is important, we think, because for many folks, this is their first time on the Navajo Nation. And, even if it's not, we have some residents who, one of our residents is Dene. We want people, everywhere. It's a very big place. So different parts of the res have a different feel. There's different cultures. There's a lot happening. And so we just want people to be spending time in the community to get a better feel of what's happening. So we have a longitudinal street medicine curriculum that our residents are very intimately involved with. They spend 1 day per week for several months going to either Farmington, Cortez, or Shiprock and taking care of our unhoused relatives with our street medicine team, and develop relationships with people. And that's a really, really enjoyable part of, people really like that part of the curriculum. And it's, it's one of the things that we do. We try to have them involved in local sporting events. The Shiprock, this is a photo from the Shiprock Marathon this year. Zara is standing up. Was the primary medical person for that event. They staff high school basketball games with our sports medicine physician. High school basketball is a really big deal in the Navajo Nation, so kind of getting to be involved in that is really fun. They also work at school-based health centers. So similar, like I was showing on that picture, of the chapters, there's schools in many of the chapters. So we have people that go to Newcomb, which is about an hour away, among other places, and spend time outside of the hospital or clinic. You can go to the next slide. We also have a longitudinal didactic curriculum that really tries to emphasize cultural knowledge and teachings and history of prevalent medical issues. So last year we had Dene herbalist come and speak with the residents. We've had speakers who talk about Dene wellness models and the health wheel, and I think just trying to give people more context and understanding of this area is the general goal for that. We also see there's certain medical issues that are more prevalent here than other places, and trying to give residents more context for that. So tuberculosis is still an issue on the Navajo Nation, and there's a long history for why that is. And so just giving curriculum on that. Uranium mining and milling was popular in the 50s and 60s, and so we see a lot of residual health effects from that in interstitial lung disease, increased rate of certain types of cancers. And so trying to just provide education for people to take better care of patients and understand the history of this area. You can go to the next slide. And really the sort of core part of the curriculum is driven from, like I said, experts. Understandably, there's a long-standing mistrust of the medical system by many of our patients and our community because of historical trauma, policies that were really problematic, things like forced sterilization, relocation. So there's a lot that we understand is coming into play when people are interfacing with both the Indian Health Service and medical care at large, and really trying to have that in our minds and be grounded in that, and use the principles of community engagement that Heather mentioned at the beginning when approaching our curriculum. So we really try to focus on having a longitudinal curriculum so people can get to know a community over time, in trying to ensure that they have cultural humility, and making community partnerships sort of the forefront of how we do our curriculum. You can go to the next slide. And so our primary community partner is a nonprofit called Healthy Native Community Partnerships, or HNCP. They are wonderful. They're a local Shiprock organization that actually works nationally with tribal groups and Indigenous groups across the country, and even in Canada in the past. Their mission is to work with Native communities to realize their own vision of wellness. They support community wellness, leadership development, and networking from the wisdom and strength of local communities. And so they have a lot of training and facilitation. They've done a lot of work in community health in different environments, and do some work around digital storytelling, do some work around community skills building, and how you gather input from communities to make community-based decisions. So they're really, we are so fortunate to have them here in Shiprock and work with them, and they are really the kind of heart of our curriculum. You can go to the next slide. So one of the things that they do is really try to help the residents learn about cultural knowledge and teachings. So every year we do a sheep to table event, which is what it sounds like. The sheep is a very important part of Dene culture. And so they do a sheep butchering, and they invite the residents. And so they butcher the sheep. As you can see in the picture here, Zara is, I think that's intestines. I don't know. I tried to pick a less graphic photo, but they kind of go from A to Z and prepare a meal and share a meal together, as you can see on the right. And so that's actually coming up next week. People are very excited about it. And so just, trying to expose residents and have a better understanding of some of the cultural elements that they might not be as familiar with. They do chapter-based talks and events about other cultural events, like our Canalda, which is the coming of age ceremony for women. And all of their events are great because the residents are invited, but so is the community. And so in general, and we often have residents and learners not from our residency program, and they're also invited. But most of the things that we're doing, we try to do in the community and have the residents and other learners join in the chapter houses across the Shiprock Service Unit. Next slide. Like I mentioned, they are amazing facilitators. That's like what they have, spent 30 years doing. And so we're really fortunate to have them work with the residents. We just, in kind of preparation for the longitudinal curriculum, we have them do an introduction to facilitation training, which just happened last week because our new interns just arrived, our R2s. And really, I think in medical school and our medical training, we get a lot of training in one-on-one interactions, but taking input from a community and trying to understand the needs of a community is a really different skill set. And so Marita and Tina from HNCP spend a couple hours with the residents, giving them sort of the principles of how to facilitate a group meeting to begin with. So you can see they always have an agenda and do group agreements and teach the residents the tangible skills to prepare them for the res cafes, which is you can go to the next slide. So the res cafes are kind of longitudinal event that HNCP hosts and that we participate in. And it's based on the World Cafe model. So it essentially is a structured conversational methodology designed to facilitate open, large group discussions. We have a shared meal with a community based on a topic of the community's choosing, and then the resident will do a short presentation about this topic. So we have gone to, I think, like 15 of the 20 chapters at this point in the Shiprock Service Unit to do these res cafes. It's been really interesting. One of the big topics that people wanted to talk about at the beginning were sort of people's experience at the hospital, and for good and for bad, and how that can be improved. So we've done that on in a number of chapters now, and taken that information and that feedback and tried to integrate it into how we deliver care here. That's very much a work in progress, but that is the goal. And the residents facilitate. We Marita and Tina, who are agency partners, do some of the facilitation, and then the residents, do a little presentation at the end of the discussion to talk about, what it's like to be a physician and what their experience is, and how you can have a better clinic visit, and questions to ask, and how to advocate for yourself. So it's really a conversation, and we've also done, people have expressed interest in mental health. So we've had our mental health department come and do discussions about mental health. Sort of exercise and physical activity is something that people are interested in, and they're planning to do that next. So all kinds of things. And again, it's oftentimes, topics that the community identifies as wanting to learn more about. You can go to the next slide. This is just a couple pictures from the Res Cafe. This is Dr. Coolidge. He's now an attending here, but this is him when he was a resident, giving his little part of the presentation. And this is Dr. Rodriguez, another one of our residents, with a community while she's talking, and we share our meal and she talks at the same time. You can go to the next slide. So one other element of our curriculum is the relationship that we have with our public health nurses. So the IHS employ, we have a health promotion and disease prevention department. We call it HBDP for short. And within that, public health nurses are housed. They're an incredible resource. They're nurses that are focused on population health. And so they're primarily going out into the community, doing home visits, sort of checking on high-risk patients. And we've paired each of the residents with a different community health nurse who we'll get to know them over the 2 years that they're here. Each community health nurse has a different chapter and community that they focus on. So the goal with that is that the residents also develop a more intimate understanding of that community over time, and can kind of try to understand the specific health needs and resources. Like I mentioned, we serve Farmington, which is a much more urban area. And, the health needs that are in Farmington are much different than Sheep Springs, which is like an hour and a half south, where many folks don't have electricity or running water. And so, what's going on in different places is very different. And the goal is that the residents kind of get a more nuanced understanding of the community that they're serving and participate in different community events in the particular chapter that they're kind of going to with the public health nurses. So they spend 1 day a month doing home visits with the public health nurses. They also will do community outreach events with them. So they'll go to vaccine clinics or health fairs. Sometimes they'll go to the senior center and talk to folks come to senior center often for like a hot meal in the middle of the day. So one of the residents just told me last time he went out and did home visits, he went to the senior center and talked to a couple people about blood pressure control and exercise at home. So it's really dynamic and kind of, whatever they're doing changes based on the month and what the needs of the public health nurse and the community is that month. And so it's pretty dynamic. Go to the next slide. So in thinking about, things that are going well, we are very lucky to have an existing infrastructure for community health and public health. Like I mentioned, the HPDP department, that is sort of what it was designed to do, was more of this larger community engagement upstream work. And so not only having the public health nurses, already doing this really awesome work in the community, but also having HNCP, which is a well-established nonprofit that is based in this area, being able to plug into those things, we feel very fortunate for that. And I think it has helped facilitate richer experiences for everybody, because there's already, a good understanding of what would be helpful, what would not. We also really try to make it community driven. Like I said, HNCP has a lot of relationships in the community and different chapters, and talks to folks and is able to get some real-time feedback on what do you want the Res Cafe to be about, what's going on for you guys right now. And so having those existing relationships with community members has been, I think, allows it to be more community driven than it would be otherwise. And then I think the residents seem to really enjoy it, and it provides a lot of sort of meaning for them. So one of the residents, when I was talking to him about it, he said, doing the Res Cafes and going out and doing home visits, it fills my cup. Like that is the stuff that I really like to do. And so I think overall it feels like, and I feel the same way. We get to go to the Res Cafes too and do home visits, and it's just really, I think, really important to get outside of the hospital and outside of the clinic and sort of reground in the community. So in terms of the challenges, I mentioned that Navajo Nation is a sovereign nation, so it has its own tribal governance, it has its own tribal judiciary system, and so the complexity of policy here is very high. There's a lot of layers of how decisions get made and how things happen, and we have wanted to kind of plug people in to do like a legislative rotation or something similar, but it has felt like it's a little bit of a black box. And so I think that's one area of growth that, in the future, I would love for us to tap into a little bit more, trying to better understand how policy is made specifically here on the Navajo Nation. People do get involved in New Mexico state legislature activities, and Dr. Coolidge, who was a former resident, is from Wyoming. So for one of his electives, he went and spent 2 weeks up in the Wyoming state legislature, where he's originally from. So we do encourage people to get some advocacy and sort of policy skills, but our curriculum, it's pretty minimal on that right now. I think one of the other really big challenges is that since we're a 1+2 program, our residents are only here for 2 years. They spend like a week here in their first year, just or maybe it's even a couple of days. It's very brief, but they're only here for 2 years. And so we're really mindful of the fact that, that's in the scheme of developing relationships and building community, that's not a lot of time. And so really being mindful of that and trying to have residents have meaningful experiences that help build skills while also ensuring that community trust and is not compromised. And then kind of like Heather mentioned, anytime you have a resident schedule, it can just be really hard to create a level of depth among that schedule. I think, there's been a number of projects that the residents have wanted to work on that have kind of come out sort of organically from different experiences they've had in their community health thread, and like finding the time to actually execute and implement some sort of project is really hard, especially in a place where there's so much policy complexity and just usually isn't realistic in the time they have here. You can go to the next slide. Things that we're hoping to do in the future, when the residents arrive, they also have an orientation month similar to what Heather was mentioning. And they, kind of drop into a variety of places and learn about the resources, but we don't have a great way of having them formally learn about that. And I think one of the really interesting things about this area is because we're covering such a large geographic area, the resources really vary community to community. And so I think we're always kind of, even those of us who have been here a while are trying to have a better understanding of what the formal resources are and stay on top of those. And the other big thing that we're working on is kind of deepening that relationship with specific chapters through school-based health clinics. So there's a couple of school-based health clinics that the residents go to now, but we're hoping to expand that. And then really working more closely with the public health nurses to kind of do almost like sort of like not case management per se, but really focus on patients who are higher risk and trying to kind of better serve them. Most chapters they keep what's called a high risk patient list, and we're trying to figure out ways that the residents can be more engaged in those people's care if they don't already have good access to care. I think you can go to the next slide. That's it.
Yeah, I think that's it. So, any questions?
So I have a question in terms of just the community engagement aspect. What has the community response been like in terms of when you host these events and you try to raise cultural awareness amongst the residents?
I think it's the feedback that we have gotten and that Marita and Tina have kind of relayed is that people really appreciate it in general and are like, I really appreciate that a doctor took the time to come to a chapter and have dinner with me. One of the first Res Cafes we did, one of my, actually our program director, Dr. Kovich, always tells the story of she was sitting next to somebody and they said, I've never had dinner with a doctor before, and just like was really excited to do that. And, we're equally excited to interact with people not in a clinic setting. So I think people appreciate it. And I think, I have found that people are, it's important to them that there is some understanding of their cultural context. And so I think people are happy that, we are still babies, but that we're trying to learn.
And how about on the resident side? What are the residents, once they become, I guess, involved in, like you said, they're babies in this sense, like once they become involved, your recent graduates, how have they felt about the process?
It looks like, Lance, are you trying to say something? I'll answer that, but so can't tell if Dr. Whitehair is trying to say something.
Hello?
Hi.
Okay. The res cafes have gone over very well, quite well. you hear it through the community, or you just hear it. Not um uh, uh, uh gossip wise, like I've heard it through. Anyway, yeah, it's gone over great. Yes, the community has responded in the very positive, that we've actually like gone out there and like been seen.
Yeah, and I think in terms of the residence experience, I mean, so we just started in 2021, so we've just had two graduating classes so far. But two of our three residents have stayed here. And I think that speaks to, and I think one of the things they say that they like about here is the fact that there is sort of more of a focus on health, just, not just in the hospital and clinic, but outside of that as well. So I do think it's impactful for them as well.
Thank you both.
Awesome. Brianna, that I think I'm really impressed with all of the connections that you have all made in just a few years. I think that's really incredible. So great work. So, all right, I guess that's all, yeah?
Thank you guys for joining us.